On an important topic of breaking bad news to good people. And since leaving us, I didn't know you UTSA.
Yes.
I'm glad to hear that.
Yeah.
Okay, well, thank you for coming.
Thank you. See, did I not tell you my phone was going to
Would you like me to yank it
I have a
out?
contribution. I don't know, does somebody need to answer it? My name is Elaine Wittenberg-Lyles. I'm an assistant professor in the Department of Communication just up the road at UTSA. And I've been working with Dr. Sanchez-Riley and the Geriatric Palliative Care team for just about 2 years now. And I originally approached her because I was interested in end-of-life care and communication, and specifically how it is that communication is impacted by the topic of death and dying, and how it is that people negotiate those sensitive topics in their interpersonal relationships within families, and originally began exploring some of these issues in this field by looking at interdisciplinary teams. So when I approached Dr. Sanchez-Riley, I asked her if I could become an honorary member of the team, and for about 6 months I spent a lot of time down here with the first team. Most of the fellows know me this year from being here working on other projects, but this is data from spending the first 6 months with Dr. Sanchez-Riley. And originally I got into this area because I became knowledgeable about the current medical initiatives for providing training in communication, and specifically end-of-life communication skills. And I became aware of some of the current curriculum out there, and I really didn't like it. And I really didn't like it because it didn't approach what I know in terms of my knowledge base in communication. It's really fundamental. And so what I'd like to present today, this project, takes what we currently have in our current communication guidelines being taught to medical students and in medical curriculum, and essentially doesn't tear it apart, but it's pretty critical. It's pretty critical. So let's start with that. No, this is. Did you not know?
I just have to.
Okay. The end-of-life communication skills curriculum and communication in medical education has come a long way. In 1997, we essentially found that there really wasn't any training, and then now we have more than 87% of medical schools in the United States require students to have some sort of instruction in end-of-life care, and specifically 87% includes a module on communication. Typically that's going to be how to break bad news because that's what they associate with. We have all sorts of other different ways that we are teaching communication skills in medical school, including using standardized patients, the LNEC, which is for nurses. We have the EPIC that I'm going to talk about explicitly, the EPIC for oncologists, the PCEP and the CAPC, which are other palliative care organizations that provide some modules or some training on communication skills. So the good thing is that we're actually focusing on communication skills as an important element that we should be addressing in palliative care education. unfortunately, I'll argue that we're just at the very beginning stages. The current modules that have been developed by physicians, which is absolutely wonderful because who else knows better than what's going on in these interactions aside than physicians. But unfortunately, and I just want to draw a little model, all of these models are based on this concept of communication, which is we have a sender who sends a message to a receiver. So in our field, this is what we refer to as one-way communication. It's just the sender sending a message to the receiver. And all of our current models that I'm going to talk about for breaking bad news are based on this idea. In our field of communication, this is very archaic. This is the very early way that we used to study communication. And we no longer look at communication transactions and the sharing of messages in this way. Can anyone think of something that would be left out of this?
Equilibrium.
What's that?
Now on the other direction.
Yeah, this thing called feedback
Yep.
that we added to our model about 30 years ago. And then this thing called, my pen's going to die here, context, which is where you say things makes a difference, who you say things to, who's in the room, who's not in the room, whether the room is hot. All of these different things about context impact what we share and how we share it. So there's really two levels here, and that is how we say things and what we say. And so far, specifically, the communication models we have just focus on what to say. In addition, while these these communication guidelines provide a starting point, we're already implementing it at medical schools, but unfortunately, nobody's tested it. We have no formal evaluation of whether or not this is working. The little stuff that we do have is that physicians say, oh my gosh, I feel so much better. I feel so much better that I have these guidelines to use when I go into these interactions that we know are sensitive and can create anxiety, and they're difficult conversations to have, particularly in bad news delivery. But we have no empirical testing to see if this is effective, particularly when you take into account the B or the patient or family. Okay? So what I set out to do was to compare our current techniques to what's really happening, because there certainly must be other things that we need to be aware of, perhaps. And of course I found out that there are. So I just want to cover two of the basic models that I used as a basis of comparison for this study. And I think that the fellows are very familiar with the spikes model. So Johnny, you're smiling. I know you've heard it like 50 billion times, but I just wanted to cover it. It's a 6-step model, and most of the models are 6 steps. And it talks about that you can plan this interaction, and the way that you do that is that you take into consideration the setting, the physical circumstances of where the bad news disclosure will be, the perception that you assess patient understanding as in terms of the disease, in terms of the prognosis, invitation that you ask the patient how much they want to know, knowledge, you actually impart the bad news, express empathy by listening or identifying emotions, and then the last one is to provide a strategy or a summary in which you introduce the next step or the next plan of care. The EPIC very similarly offers 6 steps for physicians. The EPIC is, I think it's end of education for physicians and end of life care or end of life curriculum, something like this. And again, it's a 6-step process that talks about getting started, being prepared, determining what the patient knows, establishing what the patient knows, delivering the news, responding, and then that similar kind of strategy summary, which is providing the next step of care. In both of these models, the priority is on the physician, the A, and the comfort of the physician in being able to have this interaction. So again, it's very one-way based in terms of looking at communication in these interactions. We're just focusing on the A, and it neglects to look at the B part of the interaction. Does that make sense to everybody? So initially, a scholar, Egley and al., several other authors on that byline, wrote an article that identified that there are several assumptions with these models. The first assumption is that we can actually plan these bad news interactions. Ideally, we would like to be able to plan bad news interactions, but can we always plan bad news interactions? Anyone ever come across a situation where all of a sudden you're delivering bad news and you didn't plan on delivering bad news? Yeah. A lot of the medical students, the fourth-year medical students, shared experiences like that, getting caught in the hallway with a family member or something. The other assumption with these guidelines is that these interactions involve the delivery of one piece of information, and that is the bad news. And we know that there are many other things that go along with that, and I'm going to talk about that next. We also assume that these interactions are dyadic, that there's just the A and the B. There's just the physician and there's just the patient. And I'll talk about that too next. If we do a literature review and look at all of these models a little bit more critically and taking into consideration physician narratives of these interactions, we realize there actually are several contradictions and flawed conceptualizations in these guidelines. The first is the idea of bad news. News is bad once it gets here. It can be perceived as bad here, but there's also the B part of the perception of bad news. Mm-hmm. And we have had research of studies where patients actually didn't consider it bad news in the term of the way it's perceived in this model, that they actually felt relieved, that they had such a long illness journey that when they get to that point, it's like finally, someone just finally said that I was terminal when I thought I was all along. And so it wasn't bad news in that particular instance, but the model goes into it conceptualizing it as bad news. The second one is that we are beginning to recognize that the companion or the family caregiver is also a huge part of this process, a huge part of the disclosure of bad news. They share that process of the illness journey, and sometimes more closely than we realize, depending on the patient's situation. We also see from communication research in these interactions that companions are asking about the same topics in the bad news disclosure. More importantly, we know that physicians and oncologists in particular suggest that patients bring a family member to these disclosure meetings or interactions. So automatically we're missing a C and sometimes a C and a D and an E, depending on how large or extended a person's family is in this model. And we all know just from basic communication experiences that if you are talking one-on-one with somebody and you add 2 or 3 people, that's going to change the nature of the conversation. That's going to change where the physician bases his or her attention and communication efforts. We also know that typically companions ask more questions than patients. In a study we just finished in March, we did an experimental study I'll talk about later, but we see that physicians tend to talk to the healthier person more than the sick person. And so that C, D, outside of this model, become very key people to be interested in terms of studying this communication transaction. The patient's life is another contradiction within these models. The end-of-life care model is based on holistic care, that we should focus on the patient and treat the whole person. However, these two models do not address psychosocial information, which we know is key in determining, for example, if somebody can go home on hospice, if they have a caregiver that's going to be there, so what their living situations are, and other psychosocial issues that can impact determining the appropriate pain and symptom management decisions. So psychosocial information is completely left out. Lastly, the idea that bad news interactions are just providing one piece of information is a conceptual flaw. We know that there are many elements that go to these interactions. They involve talking about hospice, they involve talking about advance directives, durable power of attorney for healthcare, code status. I'm sure I'm probably leaving something out, but there are many, many other things that go into these conversations. It's not just that, oh, you go, you tell a person that they're terminal and you've done your job. There's more to it than that. So again, this is what I did. In January through May of last year, I came and followed the geriatric palliative care team around and conducted an ethnography. Ethnographic work means that you become a participant observer, which means that Dr. Sanchez-Riley said, you need to go out and get yourself a white jacket if you're going to walk around with my team, because you need to be part of the team. Means that I was introduced to patients and caregivers as a member of the team. Made me really uncomfortable. She said, this is our communication expert. Talk about pressure, let me tell you. Communication expert, wow, you've got big shoes to fill there. I particularly chose this approach to studying this because of a number of reasons. Number one, it's a very flexible research approach. Yes, in communication, ideally, we'd like to videotape these interactions, but you can imagine how difficult that is, especially in a clinical setting when things are coming up, family meetings pop up out of nowhere, and so it's difficult in that term to plan something like that. It's difficult on this patient population. If I went in and said, can I ask if I can come in and sit and talk to you for a little bit about how your physician told you were terminal. We have a lot of studies on that, but I wanted to know how it actually occurred, what actually was said, what were the environments that these were taking place in. And it was least interruptive for me to go in as a member of the team with my notebook, as many of you all go in on rounds and you have your paperwork, so I just looked like a normal part of the team, at least I hope I did. I did not have any interactions with patients, except that I was introduced and I said hello. I never talked, and I sat in the corner or sat off to the side or stood most of the time and just wrote like crazy. And I wrote about everything that I saw. And in many of these interactions, I was able to write word for word what people were saying, because as you know, many of these patients are very sick, they speak very slowly, and most of them are elderly and frail. So I was able to capture real dialogue as it was occurring in these interactions. I've done this type of work over the last 6 years, so I have my own kind of chicken scratch way of writing really, really quickly and knowing, being able to go back and deciphering it. I also include reflective journaling, so after the days that I went on rounds, I met with the team during their team meetings. I went down to Dr. Samuel's unit a couple of times and just really tried to become as close to the interactions and understanding everything that was going on. Over the course of my field work, particularly for this study, its focus is on 11 bad news events or interactions. It just sounds so horrible, but delivery of bad news disclosures. 9 were male and 2 were actually female. So what I'd like to do now is highlight the clinical occurrences and patterns that emerged from my study in comparison to what I talked about earlier, the current communication guidelines. The first point is that the team, and working in a team environment, ensured that bad news was delivered, always. Because there was more than just one person determining whether or not it was delivered. We had a whole team. And so because of that, patient advocacy was a priority. And the team gatekeeped for itself in making sure that the patient knew. And so I want to share with you some of my examples. And this one was particularly poignant for me. Probably one of the patients I'll never ever forget in my life. And this started at initial pre-meeting or briefing or before, meeting before rounds began. And the palliative care physician fellow reported, all I know is she has metastatic disease everywhere. To multiple ribs, multiple areas, liver metastasis. She's got a lot of metastatic disease. And then her voice comes up. I guess it was in this hospitalization she found out she has metastases, just widespread metastatic disease. And she goes on and says her youngest child is 8. This is a woman. The patient was a female. And so the rest of the team just kind of sits there. And a little conversation goes back and forth about hopefully that she'll stay. And this woman had been at home. And the physician says, well, I asked her to help you get stronger. This is the fellow. We have a place here. She doesn't seem interested in that. Maybe you could talk her into that. I don't know. I can understand. She has an 8-year-old, And so the physician director says, have you talked about hospice? No, I did not. End of life? I did not talk about that. Advanced directives? I did not talk about that this morning. She knew that that was her role. She knew that that was part of the responsibility of going in on the consult service to do that, but couldn't. So the fact that they're in a team environment and somebody in the team finds maybe this is a really difficult case for all the factors that we often find cases difficult for. There's a similarity. The patient looks like someone in our family. They have a relationship similar to you and a family member. Whatever it is, the fact that an interdisciplinary team is working on it ensures that advocacy will still take place, ensures that bad news will still happen because somebody else on the team won't have that strong of a connection. At least we saw it here. It was also in this interaction that the medical physician fellow could not look at the rest of the team in this report. And so it was very interesting how she was very uncomfortable with this. And we actually did go in during the patient visit and disclose bad news. Now the medical fellow didn't do it, but another member of the team did. And so it was still delivered. If we had this model, it wasn't. So, everybody get that? Okay, the second one is redundancy of the message. Nowhere in the communication guidelines does it talk about specific communication techniques that we can use to get our message across, to still be empathetic, to still carry the conversation on. But particularly redundancy provides a number of different things. It reiterates the prognosis, and this is especially important for patients that are very early on in learning about their prognosis and don't want to talk about it and really don't want anything to do with it. But I also see that it communicatively provides an interesting transition to talking about other care decisions. So, well, maybe the patient doesn't want to talk about the prognosis, but they'll talk about code status or advanced directives, which is still a conversation included in the delivery of bad news. So it's an interesting twist in being able to still talk about something, but finding the right comfort zone for that particular patient by talking about something else that's still related to it. The feedback from patients also allow the physician or whoever is disclosing the news to really gauge the patient's understanding. And you'll see this from my examples. And this is taken from the middle of a conversation with a gentleman who had a brain tumor. The physician says, yes, but the tumor will not go away, sir. Your doctors asked me to come and see if you can do rehabilitation. The tumor's not going to go away. And the patient responds by saying, if you can monitor the tumor, and she says, yes, but the tumor will not go away. The treatment I'm receiving now, whatever prognosis you can come up with, we can give you treatment, but we cannot cure you. And so it's this continued kind of redundancy that helps to get the message across, but also keeps the conversation going. And this was a male. His particular response is an indication that the message still needs to be repeated. So redundancy works here. Third, understanding and defining hospice is necessary. It doesn't talk about this at all in the communication guidelines. At all. And in medical students, fourth-year medical students that we did a study on 2 years ago and this year too, many of them didn't understand hospice or what hospice was. And in my observations, I see that this is so key to having these conversations. Understanding, defining, explaining, and really educating about hospice. And the talk about hospice further elaborates on just giving the terminal prognosis. Again, it can provide a quick assessment of the patient's understanding, acceptance. And I actually saw that while patients were very reluctant to talk about terminal diagnosis, patients and families actually indicated that that talk about hospice was actually a positive part of these kinds of conversations. I mean, the conversation really turned to what I felt was a sense of closure and a sense of having some sort of control that they could plan something. Specifically, this goes back to the woman that was that I shared in the original example. Do you know what hospice is? And she responds, it's when they come and take care of you to the end. I'm not ready for that. I'm not ready for hospice. Can I ask why not? I'm not ready for hospice. I'm not ready to leave yet. So it's clear that this particular patient wouldn't talk about diagnosis, wouldn't talk about hospice. So the physician goes back, well, let's talk about your pain, and then brings up the topic of power of attorney, which was very comfortable for this particular patient. She had no problem talking about power of attorney, and once the physician finished talking about power of attorney, she went back to hospice. And so it's this kind of being flexible in approaching all of these different topic areas to continue the conversation. Another example from another interaction, and this comes from the middle of a discussion. The other part of the plan, once radiation is complete, you want to go home. Have you heard of the term hospice? What do you think it is? Hospice is a benefit and could happen at home. It's for people who have incurable diseases. And the patient says, like mine. And the physician responds, yes. Now we have to think about a later time when you will be doing so well, and keeps going. So the discussion and bringing up hospice provides this patient with an opportunity and actually with evidence for the physician that in this particular case he was male, understood that his disease was not curable. So it's a good indication of where this particular patient's at in terms of accepting the prognosis. Lastly is that I see that the palliative care physicians and the team that I followed have the onus and responsibility of transitioning patients from treatment mode, survival mode, into the bad news terminal prognosis. And so we see that patients are in the modality of treatment and survival and fighting the disease, and particularly cancer patients who have multiple specialists and meet with oncologists. And the palliative care physician doesn't just come in and deliver bad news, but he or she comes in and has to do this through some sort of interrogative process in terms of the 6-step spikes model. And so we see this transitioning occur. What do you think about your disease? Now, this was a patient that was just early on. Not much. And she says, at this point, the cancer's not curable. Well, they haven't actually said that. And so just shuts the conversation down. And she reiterates, it's not curable, but it's a very slow cancer. What we're concerned about is your comfort. Are you in pain? And so then we can talk about pain and go back to talking about the prognosis. Later in the same conversation, she begins to explain hospice. Well, actually, it's for individuals with advanced disease, and your disease is considered advanced. Again, the talk about hospice is another way to introduce the topic. God, you're an optimist. It's not about being an optimist, it's about being real. I mean, clearly, this is the first time this patient's ever heard this type of conversation or communication. Another example.
Did the patient mean to say optimist or pessimist?
Optimist.
Did she mean to say it?
Mm-hmm.
Okay.
this is another interaction. What's going to happen to you? And this patient says, I believe I'm going to come out of this as normal, as well as normal, because I believe this, because I've stayed. And he starts to go on. And the physician says, what did they tell you about the tumor? Similar comments from the doctor. It seems I'm going to come out of this. And this is the gentleman who had several brain tumors. But this is what other physicians and other team people either have told him, or this is what he has believed he's been told. So having an understanding of this coming into these interactions is the circle, the context of which we're coming into these interactions is very important in how we gauge our communication and how we strategize for these disclosures. So just to kind of pull this all together, the patient and physician are set up for a very emotional time based on the pretense of previous treatment regimens. So again, the physician goes in and asks, essentially in the bad news disclosure is transitioning from fighting the disease, we're going to cure it, to focus on quality of life. And all of these are addressed far too simply within communication guidelines, or they're not addressed at all. And really they're not addressed at all. What I think that we need to do is to start focusing on physician education and communication training curriculum, is focus on the different interactions, the different directions communication in these interactions can actually go. Specifically, interdisciplinary work benefits all parties. It benefits the physicians, the social workers, everybody, including the patient and the family. I mean, from my study, it shows that patient advocacy is a priority and remains a priority. That bad news is delivered, even though people are uncomfortable, on the A side of it. Redundancy is a beneficial strategy. It allows us to still convey news, but in a more comfortable and comprehensive manner for the patient and the family. Talk about hospice is necessary. I didn't see any interactions where hospice was not specifically addressed, and yet the models do not talk about introducing this as part of the conversation. But more importantly, flexibility and adaptability are key. We're currently training physicians specifically in a linear step process. This, here you are A, going directly to B. And we're not taking into account all of the different ways that we can still convey a message by transitioning from topics or being redundant, and by taking into consideration the context in which these interactions are taking place, whether or not caregivers and companions are there, how much we talk to the caregiver and companion compared to how much we talk to the patient. All of these are different elements that go into this process. In follow-up work from this study, we just did with the team this year a study with the medical students who took the palliative care course. We had half of the students taught in the spikes model that I briefly went through. The other half of the students were taught in a communication-based model on this idea of what we in communication call a transactional model. And so we are currently going through and analyzing videotaped interactions with standardized patients to see if that if there's a difference there in terms of specifically how empathetic we can be in these interactions. So, covered a lot of stuff. I covered it pretty fast, and I know that you all are burning with questions and comments and commentary for me, so I'd like to open the floor to that now. Not everybody at once, though.
I was going to say, how come in the beginning a lot of this was not based on the people who are sort of do communication all the time, such as the social workers and the psychologists, introducing those things? Because what you're talking about is the basis of what we do all the time. Yeah. That is the model we use. So sometimes when I was getting some of these other models, it was like, whoa.
Yeah.
Yeah, it's a little strange.
There's a lot of research out that actually show that nurses and social workers deliver bad news more than what we would think that they would be. And there not to my knowledge in terms of curriculum and training out there. It's just fly by night. The other thing is that in addition to teaching these types of linear modules, most of the communication education rests on role modeling, which is just go and follow your preceptor and go follow a resident or attending. However, there's a lot of flaws in that because we find that there's not often enough time to actually stop and turn a role modeling experience into an educational experience, and particularly in terms of teaching communication skills, because we don't get that reflective part of role modeling. So you follow somebody around and you think you're learning something. Well, the real education comes in sitting with that person and then saying, you know, I did this, and you know when I did this because. That's the learning part of it. And so 67% of U.S. medical schools right now consider role modeling as the key part of communication education, but it really is lacking in terms of instruction. Dr. Samuel, you were going to volunteer.
I was going to say the reason why the reason why the social workers and other communications experts aren't involved in the process more is because medical education, EPAC, all that other stuff is run by doctors. And so I think it's the way that physicians are trained, and not to say that we're not trained by social workers at various points, but those points are generally very early on in medical education, first year, second year, at a point where the medical student is not has no basis of experience with which to learn. So you're kind of preaching. You're kind of trying to teach auto mechanics to somebody who's never had a wrench in their hand,
Right.
and
Or
it's
a
just,
car.
and it goes in one ear and straight out the other, or people retain it, but the real education they get is when they start doing apprenticeship type activities. And so anything they learn before those apprenticeship type activities, unless it's regurgitation of facts, is going to, just all those attitudinal things go straight out the door. It's about as relevant as chemistry lab in college by the time people get up to that point of their education. Now, I mean, there are exceptions. I mean, if I'm a family doctor. I was on I was in a family practice faculty. We're required to have active involvement by psychologists and other professionals in the training of our residents, and so we have a little bit of an advantage. But basically, it's an apprenticeship model. Doctors make this stuff. The Spikes model is created by a physician, and it's the monkey see, monkey do.
And it's really a larger picture than that too. It's based on how we feel about communication. If you think that you can actually learn communication skills, if you think that that's going to be valuable to you, or if you think like so many medical students say when I talk to them, communication skills, you either know it or you don't know it.
Well, I think
there's a huge part of that I myself, as a scholar, communication scholar, do believe in.
And I think you're making this further assumption that medical students and especially residents and faculty actually think about those things. They don't. I mean, it's just there's I can't remember what I was going to say. It's not directly saying there's no time for that, but it is irrelevant to the manner in which they're trained. Now, how could you change? How could social workers teach how to change? Simply by, if you had very active, assertive social workers involved in medical educational settings who were proactive in a teaching mode. Physicians who go to work for major medical centers are proactive in teaching modes. Social workers who go to work for major medical centers, they don't view themselves as a teacher. And so, everybody's been involved with more than, residents are involved with hundreds of interactions every year with social workers. It is very rare that those social workers are actually interested in teaching the residents and teaching the medical students. The ones who are, generally, they teach the teaching remains on a concrete level of, oh yeah, this is how this financial and social service system is set up. And that's very valuable education, but I think the difference is that the social workers who are in the mix don't view themselves as, hey, I've got residents in front of me, I'm supposed to teach, and of course social workers slip into that mode of what doctors think social workers are, people who get my patients out of the hospital, and get them some money, as opposed to what social workers think their role as social workers are, which are as
And that's an excellent
communication
point.
specialists,
That's a
among
good
other
point
things.
in terms of goals and interactions. You know, the way that the models are currently set up, the communicative goal is to go in and disclose the news and you're done. And we're seeing a whole transition, more focusing on patient-centered care and being able to relate to your physician and liking your physician as a factor that leads to maybe increased patient compliance and all of these different things. So if you go into this transaction and your communicative goal is to deliver bad news, and you say, I'm so sorry, your prognosis is terminal, you've delivered your bad news. But if your goal is to go into this encounter and be empathetic in delivering that bad news, then you are interested in garnering some additional communication skills to be able to accomplish that secondary goal. If we kind of inherently determine that, well, it's a communication, you either have that skill or you don't. Well, it depends on if you're talking about achieving multiple goals in particular communication interactions.
I mean, the spikes protocol was developed as a way of increasing what you had said, which is to be able to empathetically deliver news. I mean, if I had to say it, doing your job means going in there and telling a person they're going to die. The spikes protocol, if I had to put it into one sentence, go in the room, tell the patient they're going to die, and don't leave until they finish crying and asking questions. Which, of course, most of these people, about half the people don't say anything, so then the spikes protocol falls apart because you have this, silent patient who may say, okay. And, I'm lucky because I can leave the room and go back to them a couple hours later and talk to them again because I'm physically in the same locality. Most people can't. And so, the looking at it as an interaction, that's what's actually got to go on beyond spikes.
Mm-hmm.
Which is basically, tell them the bad news and deal with the emotional response. Which is progress.
It's
but
great progress. I mean, I'm presenting critical work, but I think it's very exciting. I think it's great progress that medical education is interested in these issues. It's a great start. It's on the table. It's definitely a place to start. Well, thank you all.